Good evening. I know it's been a very long day. I'm not so sure how much everyone has seen this disease, the necrotizing fasciitis. It's so this is something which it's not so commonly seen in most of the places. Where I came from originally, I had just seen one case, but currently where I'm practicing, that's in Queen's Hospital, we get a case almost every 2 months. But of recent, we've had almost 5 cases in 3 months, which is quite common. And this is something which I have been quite interested in. So what I was fascinated about was there's a lot of literature regarding what are some of the investigation modalities which are used for necrotizing fasciitis. Although the mainstay of diagnosis is clinical till yet. So that's what I wanted to say. I've put some few images. I'm sorry if it's a bit foul to some of them. So this is a young lady, 57-year-old. She had cancer of the breast and she was on active therapy. However, she developed this lesion. But one thing I will highlight as we go in this presentation is that this patient had an LRNEC score of just 4 or 5, and that's just if you are to see the classification, it's a mild risk for necrotizing fasciitis. However, this is her intraoperative management because we clinically diagnosed it as necrotizing fasciitis. I think there's some smoke there.
Yeah. Please take no action.
Should I continue?
Attention, please. The fire alarm is about to be tested. Please take no action. Attention, please. Attention, please. Please leave the building immediately. Please leave the building immediately by the nearest exit. Do not use the lifts. Attention, please. Attention. Please leave the building immediately. Please leave the building immediately by the nearest exit. Do not use the lifts. Attention, please. Attention, please. Please leave the building immediately. Please leave the building immediately by the nearest exit. Do not use the lifts. Attention, please. Attention, please.
All right. So yes, as I mentioned, this young lady, 57-year-old with cancer of the breast, was undergoing therapy. She developed this lesion, which we clinically diagnosed as necrotizing fasciitis. However, she was having a low LRNX.
The fire alarm test is now complete.
Thank you. All right. So I will mention something.
Attention, please. The fire alarm test is now complete.
Thank you.
Please respond to all future fire alarms.
Are we done? Good. All right. So yes, that's how her intraoperative imaging looked like after debridement. But if you have a look at this image of the CT scan, it's quite evident from that point of view that is that subcutaneous emphysema, which there's a lot of gas there. Okay. So that was a diagnosis which was mostly clinical, but then it was aided by imaging at that point. So background, a necrotizing fasciitis is a very, very rapidly progressing disease. I've seen it progress within half an hour, 1 hour as well. It was just a recent case. It's normally can be confused as a cellulitis. There's a spectrum of symptoms which you could see in this. So you might earlier on see some features, something like pain, swelling, and fever, which is just like any inflammatory condition. And it can be confused with cellulitis, as I mentioned. However, classic symptoms do appear, but very late, like in that case. Diagnosis, as I mentioned, is mostly clinical. And however, there are other modalities which help us with the diagnosis, just like the LRNX score, which is a score which is made up of multiple parameters, including things like glucose, the white cell count, the CRP, the creatinine levels, sodium levels. That's a score which is amalgamated by getting all these parameters. Other things like the imaging, which we have the X-rays, which can be easily done, a CT scan, an MRI as well. However, the main thing is prompt recognition and surgical intervention. Usually you have to take this patient immediately because they have a septic, they usually throw septic emboli, and that patient can easily die in the earlier, if not taken quickly. So what we did was we had a look at the past 2 years. I didn't include this year's cases. That would have, the tally would have gone up to 16, 17 by then. We looked at their demographics, the comorbidities, the clinical features with which they came with, the laboratory and imaging findings, and some of the outcomes of these patients. However, my study is more limited towards the imaging of the modalities which we use for diagnosis. So if you are to have a look at this, the mean age presentation of the patient, the mean age of any patient who was coming to us was about 57.6 or 58 years of age, with roughly the same male to female ratio. And about 67%, as most studies suggest, had diabetes. Other comorbidities included something like chronic kidney disease as well. Cancer was another comorbidity with which they presented with. However, we did have many patients who actually did not have any comorbidities. One of our own consultants had necrotizing fasciitis, but he was a pre-diabetic, but like almost tending to pre-diabetic. That's what I can say. So this is a condition which we need to have a very high index of suspicion. As I mentioned earlier on, some of the presenting features are quite vague. You might just have pain, erythema around that place, and swelling, which really mimics like a cellulitis. And a lot of the cases which we had was a severe, because now this is graded under severe skin soft tissue infections. We had severe cellulitis, some patients, even some patients with pyoderma gangrenosum were being diagnosed as necrotizing fasciitis until we really made it a clinical diagnosis. If you have a look at the graph there, it really shows the same thing which I mentioned. Pain, swelling, and erythema were the majority of the patients presented. Very few, the subcutaneous emphysema, which is a pathognomic feature of necrotizing fasciitis. Very few, just one patient really, or one or two patients really presented with subcutaneous emphysema. So that's the reason why high suspicion of index, I will really highlight on that point, and I've mentioned it a lot, I know, but it's something which you have to keep in mind. If you have to look at the LRNX score, so average score, although it was about 7, but you will see about two patients had a score less than 5, and similarly, about 2 patients had a score of between 6 and 7. And one thing which was of notice is that the patients who had a score of less than 5 are the ones who had 1, the mortality, and 2, they had the highest. They had the highest mortality. The one because they were taken to the theaters very late as a result of that. And if you have to have a dive into the LRNX score, which is basically the laboratory risk indicator for necrotizing fasciitis, what we saw was that in this score, the CRP, sodium, and creatinine levels were the main drivers of the score. The other factors like the white blood cell count although it has three sub-parameters of white cell more than 25, 20 to 25, and then less than and more than 15, very few of the patients actually had a count more than 15, or let's say more than 20. If to note, only one patient had a count more than 20, and none of them actually had a score of more than 25. So that was slightly worrying regarding the score. And in terms of outcomes, if you have a look, most of the patients were taken to theater within 12 hours, which is a good thing. However, there were some, as I mentioned earlier on, who had a very low LRINX score, who were taken to the theater much later, one being taken almost 9 days later. And this is a patient who did very badly and was unfortunately passed on as well. The in-hospital mortality was about 22%, so 2 out of 9 patients, which is a fairly good number compared to most of the literature which is around. And if we had to look at the imaging, although we didn't image every patient who was there, as I mentioned, it was more of clinical. CT was the one which was mostly done, and only about 2 patients actually had positive CT findings of subcutaneous emphysema, one of which I just showed. The others just literally, the features they had was just subcutaneous, some form of edema around the site of infection. So it had CT scans had a positive rate of about 50% compared to the 84% in literature. And X-rays really, it had although it is used, it has a very low diagnostic value. So one of the discussion points is that clinical presentation is usually variable and classical features are usually not so present. The LRINX score alone is not sufficient and should not guide your should not be the sole guideline for your decision making. You usually require a multimodal form of approach, that is clinical suspicion, the labs, imaging, and also prompt senior review, to be honest. Some of the limitations, although the hospital incidence and prevalence of necrotizing fasciitis is much more than what is in the country, this was still a small cohort. And it's a single center retrospective study. There was some there could have been some form of documentation bias as well regarding that. Conclusions, there is no single modality which is sufficient. Main thing is having a high suspicion of index and rapid escalation to save really the life. Future directions. One thing I've come across was developing standardized protocols for such, especially in settings like ours where this condition is quite very common. Recent papers have also suggested that there could be some impact of artificial intelligence as well, actually. There was one paper which was recently published by Wu et al., which mentioned use of machine learning and artificial intelligence and had a sensitivity of almost 84%. Although it is still much more in the development stages, it is one thing which we could use as an aid to diagnosis in the future. These are my colleagues who took part in this. Yeah, thank you.